try to understand what this clinical anatomy means, because it is basically learning to correlate basic anatomy with the diseases. Okay, and let us begin our lecture today. So I hope you guys can see this. Okay. For today's lecture, this is a free lecture. We will be doing these topics, okay? The blood supply of the GI tract, photosystemic shunts, the pectinate line, digestive tract, and histology. So what I did was, I took the most hardest topics in GI tract, this, especially these two. And I decided I'll do it on the first day itself, okay? Tomorrow we will have topics including these. We'll go into the liver, gallbladder, the ligaments, and also another hard topic, a very hard topic actually, the inguinal canal. Okay, so let's begin our lecture. Okay, now first let's take a look at the digestive tract histology. There are, okay, if this is our GI tract, there are several layers in the wall. Okay, there are several layers of the wall. The innermost, where the foot passes through, can someone tell me the name? What do you call the region where the foot passes through? The open region.
The lumen.
Yeah, it's simple. Okay. Now, outer to the lumen, we have a layer of tissues. What is this tissue layer called?
Mucosa.
Mucosa. Can someone tell me the layers of the mucosa? This is the, what are the layers of the mucosa?
Outermost should be epithelium.
Yeah, there's the epithelium. What is below that?
Lamina propria.
Yes. So this is the epithelium. And what do you call this, the structure that these cells stand on? Basement membrane. Yeah, basement membrane. And then below this, we have a connective tissue layer. Over here, we have glands. We'll talk about different glands. Then there's blood vessels, small blood vessels, okay? Remember, these are small blood vessels, not major blood vessels. This is the region of the lamina propria. Lamina propria. And finally, we have a muscular layer. Can someone tell me the name of this?
Muscularis mucosa.
Yeah, muscularis mucosa. Okay, this is the first layer. Next, let's go to the second layer. What do you call the second layer?
Submucosa. Submucosa.
Submucosa. Sub means below the mucosa, okay? And this is pure connective tissues. It has a lot of connective tissues, a lot of blood vessels. And also there's a very important structure here. There's a nerve plexus. What do you call this nerve plexus?
Mesenteric plexus.
Yes, it's called the Meissner's plexus. And let's begin our first anatomical correlation to diseases. This Meissner's plexus is damaged in a disease called Hirschsprung's disease. Okay, Meissner's plexus is damaged in a condition called Hirschsprung's disease. We'll talk a bit about that, but this is a topic that comes under pediatrics and surgery. Okay. Next, we have the muscular layer. The next layer is called the muscular layer. So it has two types of muscles. Can someone tell me what the two types of muscles are?
Circular and longitudinal.
Yeah, inner, which is inner, which is outer.
Outer is longitudinal, inner is circular.
Yes. So we have a circular layer of muscles. Why did I draw it like this? It means it goes this way. When you cut a slice of the GI tract, you will see these muscle fibers traveling this way. Okay, and leave a space in between. The other type of fibers is called the longitudinal layer. So the inner circular layer, inner circular, and the outer longitudinal. Can someone tell me what's in the middle? Another important
Orbic
structure.
plexus.
Yeah, the orbic plexus. Okay, let me draw that. This is also a nerve plexus. Okay, and now we talked about these plexus. What is these plexus? They conduct the nerve impulses to these regions. So the nerve signal to the submucosa. Can someone tell me what happens there? What does the nerve plexus related to the submucosa do? It controls the secretion and the blood flow to the GI tract mainly. Okay, there's also some movement. The Auerbach plexus, it is strictly for motility. This has gland secretion, then blood flow, control the blood flow to the GI tract, and also some degree of motility. Okay. Basically, the thing you need to understand is if these two plexus do not work, the glands don't secrete, and also the GI tract doesn't move, food doesn't move forward. Okay. And finally, can someone tell me the last layer? Serosa. Okay. Okay, there's two types. There's the mesothelium, and there's the retroperitoneal, the adventitia. Let me come to that. So the mesothelium is seen in intraperitoneal organs. And the adventitia is seen in retroperitoneal organs. Now, I will talk about intraperitoneal organs and retroperitoneal organs. Nishant, can you please erase this? Yeah, thank you. So tomorrow I will discuss the organs which are intraperitoneal and which are extraperitoneal. But what you need to know is if this is the GI tract and if it contains the mesothelium, it will secrete a lubricating fluid. The mesothelium secretes a lubricating fluid which will help the motility. Okay, because the intraperitoneal organs such as the duodenum, the organs, the small intestines, different parts are retroperitoneal, intraperitoneal, we'll come to that. But because they're so close together, it has to be lubricated. Okay, because they move close to each other, it can cause friction, it can cause damage. It has to be well lubricated. In the adventitia, we have loose connective tissues. Loose connective tissues. Basically, it's just the wall, and it is not lubricated. Okay. This is it for the introduction, the digestive tract histology. If you guys can understand this, you guys are golden. Now, I will talk a bit about Hirschsprung's disease, and also this I forgot to mention here. Auerbach plexus is involved in a disease called achalasia. Can someone tell me where achalasia is going to damage? Where's the pathology? Achalasia?
Esophagus.
Esophagus. Okay. let's talk about Hirschsprung's disease. Sorry, wait. It's SPRUNG. SPRUNG disease. Now, Hirschsprung's disease, it's a pediatric disease, okay? Pediatrics is the study of diseases in children. And it's seen commonly in Down syndrome patients. Okay, it is seen more commonly in Down syndrome patients. And also what happens is, there is a failure. This is the pathogenesis of neural crest cells to migrate. I'll explain the statement. Okay. The disease is a condition in which there's a failure of neural crest cells to migrate to the rectum and the distal colon. Okay. What are these neural crest cells? This is under nervous system embryology. These are the structures which travel to different locations, such as that it forms the adrenal glands. These cells, they go to different locations and they form these nerve plexus. It forms these nerve plexus. Okay. So what happens is, we have our large intestine, and in the most distal regions, in the last regions of the digestive tract, those cells fail to migrate. They will come, they will form the nerve plexus in all these regions, but in the distal colon, so in the distal colon, they will not migrate here. Okay, they will not migrate here. So what this means is, these patients are unable to move stool forward. Now we have our normal GI muscles, then we have our abdominal muscles. You need to contract. Okay, our normal GI muscles alone can push the feces at least to the end. Then when you contract your abdomen, the feces is going to come out. But these patients don't have this support. It doesn't have the support of the GI tract. So these patients present with something called explosive feces. Okay, they present with something called explosive feces because they need to strain a lot, and because there is no slow peristaltic movement, it is just going to come out really fast. Okay, and the other thing you need to know is, there is going to be something called, okay, I won't go into clinical details much here. I will talk about what's relevant here. We need to do something called a rectal suction biopsy. We need to do something called a rectal suction biopsy. Now, the word suction here is important because normally, if you are to do a biopsy, you will take cells. So what is a biopsy? You take cells from somewhere. Let's say there's a tumor. You send a needle and you take cells out. And then you look under microscope. That is basically what a biopsy is. Normally, you take the epithelium. You use the device and you take the epithelium. But then the epithelium is just the endoderm, sorry, the mucosa. We won't see anything. We need the submucosa also, okay, in this condition. So what you need to know is, for Hirschsprung's disease, you need to do something called a rectal suction biopsy, where you take the mucosa and the submucosa. And the treatment is basically you cut this off, okay? The treatment is resection, okay? It's a surgical disease. You need to take the mucosa and the submucosa. This is Hirschsprung's disease. Let me, yeah, I'll give you guys a few more seconds. Next, we have achalasia.
Shan,
Yeah.
how is it related to Down syndrome? Like, is there a correlation
Uh,
due to the 21 chromosome, or?
yeah, it is due to the trisomy of chromosome 21. But then it is most, so the thing is, when there's a chromosome abnormality, there's going to be several defects. It's not just going to be one place. Okay, it's not going to be just the height might be shorter. It's not just that. They will have multiple defects, and this is one of them. Okay, let me tell you one more thing. So Down syndrome patients are patients who have trisomy 21. Okay, trisomy 21. Okay.
Shan,
Now, yeah,
is it a surgical emergency?
it's not a surgical emergency, but yeah, okay, I understand what you mean. So these patients will have the failure to pass meconium.
That,
Okay?
yeah. Like,
If that's
so
the
it will be
case,
similar.
if that's the case, yes, it's possible. But then it depends on the patient. It depends on how badly he or she is affected. There's different degrees. Don't think too much about that. Let me just tell you something about Down syndrome patients, because Shashank asked a question. So this is associated with trisomy 21. Also, there's a gene in our 21st chromosome, which is related to Alzheimer's disease. Okay, Alzheimer's disease. So if there's some sort of a defect in this gene, in normal people, the risk is magnified by 2 times. Okay, in normal people, the risk is multiplied by 2 times. But in Down syndrome patients, they have 3 times the risk for Alzheimer's disease. Okay, this is something very high yield in neurology. I just wanted to mention, so Shashank asked, how is it related to Hirschsprung's disease? It's just, since it's a chromosome abnormality, it is going to have multiple problems. Okay. So let's go into achalasia. Now, achalasia is a surgical emergency. Okay, it's a surgical disease. It is because of 2 things. There's a lower esophageal sphincter. The lower esophageal sphincter this fails to relax. So when food goes down, it fails to come back to its normal size. Okay, it is going to be overstimulated. It is going to be overactivated, and also this is the first cause. The second one is absent peristalsis. Okay, in this region you have absent peristalsis and the failure of the esophageal sphincter to relax. So what happens then is the food is going to come here. Food is going to come here. It doesn't have a place to go. It can't go down to the stomach. Okay, and that will cause dilation of, it will cause massive dilation of this region. Okay, because of the food accumulating there, the esophagus is going to enlarge. Okay, and this is called the bird beak sign. Which is seen in barium swallow. Okay, let me show you an image of this. We'll discuss a bit about radiology of the abdomen, but let me show you an image. See, you can see this, the constriction here, and then massive indentation here. Okay, this is called the bird beak sign. Okay. This is due to a defect in the back plexus. Okay. So this is achalasia, and I hope you guys understand the histological importance to these diseases. Next, let's go to the blood supply of the GI tract. Okay. So we have some cases. Once I explain the stuff, we'll come back to these cases. Okay. Now let's go to a new page. Okay. Let's go all the way back to embryology. Okay. Here is our fetus. Okay. This is our fetus. And the fetus is going to grow out like this. I'm going to use 3 colors from this point. If you can, try to use 3 colors. Okay. Just draw this with me. I'll explain everything. Okay. Just draw this with me here. So someone who has done pediatrics, those lectures, can someone tell me what are these structures? I did 6 of them. Can someone tell me what these are?
The pharynx.
Yeah, it's a pharyngeal pouches. Okay. Now, this region, which I drew in green, is called the foregut. Okay, the region I drew in green is called the foregut, and the foregut will give rise to the stomach, the esophagus, stomach, then the liver, gallbladder, and the pancreas. Okay, so this will give rise to the pancreas, this will give rise to the liver, then the stomach, and the top part will give rise to the esophagus. Okay, this is supplied, this entire region is supplied by which branch of the abdominal aorta?
Iliac trunk.
Yes, it's supplied by the celiac trunk. Okay, and over here I drew this out pouch. It is called the Vitelline duct. Okay, now this region is called the midgut. These names are not hard: foregut, midgut, and hindgut. Let me label that also, hindgut. The midgut is supplied by which artery?
Superior mesenteric.
Yeah, it is going to be supplied by the superior mesenteric artery. And finally, the hindgut. What's the artery?
Inferior mesenteric.
IMA, inferior mesenteric artery. So superior mesenteric artery and inferior mesenteric artery. Okay. Now, why did I mention this vitelline duct? Because we'll be discussing this in a later lecture. But if the vitelline duct does not get destroyed, if it does not regress, like in the sense it will atrophy. If it doesn't happen, it leads to something called Meckel's diverticulum. Okay, it can lead to Meckel's diverticulum. Okay, this is going to be discussed later, but for now, just understand this is called the Meckel's diverticulum. Okay, now let's take a look at these structures again. We have the esophagus, then we have our stomach, then we have our pancreas. Okay, next, okay, guys, I'm gonna change the color. Okay, it's fine, it's fine. From here, I'm gonna change the color. This is the small intestine. To join with the large intestine, the ileocecal junction. Just draw this with me, I'll explain this. So up to the 2/3 of the transverse colon, 2/3 of the transverse colon, use the other color. And the final part, use the third color. So over here we have the esophagus. Then we have the stomach. And I'm going to add one more organ here. It's the spleen. Okay, it's the spleen. And here we have the pancreas, the bile duct, etc. Okay, and this region, this point, it's called the ampulla of Vater. AMPULA of Vater. Okay, this is called the ampulla of Vater. And up to this point, all these structures are supplied by the celiac trunk. All these structures are going to be supplied by the celiac trunk. Okay. So the ampulla of Vater is a part of the duodenum. The first part of the duodenum is going to be supplied by the celiac trunk. The next thing is up to the location of over here. This is 2/3 of the transverse colon. It is going to be supplied by the, so the small intestine. Okay, let me label it. Small intestine. Then we have this large intestine, the appendix. All of these, they are going to be supplied by the SMA, superior mesenteric artery. And finally, from 2/3 of the transverse colon to the end, to the rectum, it is supplied by the IMA. Okay, you guys understand this? The reason I did the embryological structures is so that you guys can remember this better. You guys can understand why the liver is supplied by the celiac trunk, why which regions of the superior mesenteric artery is going to be supplied, which regions of the small intestine is going to be supplied. Yeah, so that's it for the introduction to the blood supply. Next, let's take a look at the abdominal aorta. Okay. Let's take a look at the abdominal aorta. First, I'm going to draw the regions in the sense related to the vertebral column. I'm going to draw the regions. Oh, sorry. Just make sure you have space between at least 2 lines in your note, if possible. This level is the T12 level, the L1, L2, L3. Okay, simple. Now, let's take a look at each part and the importance of each part. From here, let me tell you something important. GI innervations, GI vessels originate anteriorly. So other vessels originate laterally. Let me explain this. The GI vessels, the celiac trunk, the superior mesenteric artery, and the inferior mesenteric artery, they originate anteriorly from the front of the abdomen, okay, facing this way. Other vessels, such as the renal artery, so the renal arteries, they will go this way, okay, towards the liver. Sorry, the kidneys. Renal arteries will originate laterally, okay. This is the celiac trunk. It's going to come laterally, anteriorly. Okay. Next, we have the superior mesenteric artery. Okay. And I'm going to use another color, but then we have the renal arteries, the gonadal arteries coming like this. Renal arteries, gonadal arteries. And when it comes to this point, L2, between L2 and L3, make sure you leave some space in this region, okay? Draw the artery somewhere above. I need to tell you guys something important here. This is the IMA, inferior mesenteric artery, okay? At the level of L4, sorry. Let me change the labels a bit. L3, L4, okay? At the level of L4, I changed the regions of L3, L4. I just took L3 a bit up and added L4. So we have the common iliac artery, which bifurcates. It forms 2 branches at the level of L4. And over here, can someone label this? The one going inside? The first one.
Internal iliac.
Yes, it's the internal iliac. This is the external iliac. So this is pure anatomy we are doing right now, okay? Now I'm going to add something clinical. Can someone tell me which region will be affected by the condition abdominal aorta aneurysm? Abdominal aorta aneurysm. Which region? I gave you guys a hint earlier.
L.
Which region? L3. Okay, in the region of L3, somewhere here. there's a condition called abdominal aorta aneurysm. So this is the abdominal aorta, and it can cause something, it can form something called abdominal aorta aneurysm. The abbreviation is AAA. Okay, this is when the wall of the blood vessel, this is an artery, okay, and the artery is going to have a lot of pressure. So what happens is the pressure is going to hit the walls, and it can cause enlargement of the artery. Okay, it will weaken the wall. Okay, now to treat these patients, you need to do surgery. Okay, RX means treatment. To treat these patients, you need to do surgery. And what you need to know here is, while doing this, there's a risk of damaging the IMA. There's a risk of damaging the inferior mesenteric artery. Okay, so you need to understand that, and you need to be able to clinically correlate that. That's the first point I need to highlight. The second point I need to highlight is called horseshoe kidney. Remember, I did this 2 days ago. I talked about how the ureteric bud, which originates here, it has to come all the way here. Okay, don't go to draw this if it's gonna miss. Okay, it's supposed to come up all the way here. Since it's on either side, it normally can go up. But in a condition called the horseshoe kidney, so it's going to be like a horseshoe. The kidney is going to be like a horseshoe. There's going to be an attachment here. Okay, while it goes up, it is going to get stuck here. Okay, while it travels upwards, it will get stuck here. And most of the patients, they don't show any symptoms. They don't have any symptoms, but they have a higher chance of getting calcium stones, sorry, calculi, renal calculi, kidney stones. Okay, that's the second anatomical thing you need to know about this. So before we go into the, I'll explain that when we come to the cases, sorry. Let me duplicate this page. Okay, next, let's take a look at the celiac trunk. So the celiac trunk is the first branch of the abdominal aorta that we're going to discuss today. Okay, supplies four gut structures. Okay, what are the four gut structures? Can someone tell me?
Pharyngeal pouches.
Sorry?
Pharyngeal pouch.
No, not the pharyngeal pouch. That is something entirely different. It's going to give rise to some other structures. It's not related to our discussion.
Okay. Take us till the starting of the duodenum.
Yeah, to the point of the ampulla of Vater. So the esophagus, the stomach, the spleen, the liver, the bile duct, the the gallbladder, and the pancreas, and a bit of the duodenum. Okay. Now the celiac trunk, let's just draw it, has three main branches. What I'm drawing here is the stomach, and over here I'm just drawing the spleen. Okay, let's take a look at this blood vessel. So the celiac trunk is going to give rise to 3 branches. Okay, does anyone know the name of the first branch?
Left gastric.
Yes, the first branch is the left gastric artery. It supplies this region. Okay, also it gives a branch to the esophagus. Okay, this is the left gastric. Next, we have an artery which goes to the spleen. Okay, check that region I made. Can someone label this artery?
Splenic artery.
Splenic artery. So 2 things I need to highlight. Left gastric gives rise to the esophageal. It's an esophageal artery. Okay. The splenic artery gives rise to 2 things. It is called the gastroepiploic artery. So this is called the gastroepiploic artery. It's the left ones. Okay, and short gastric arteries. Okay, the third thing is, can someone tell me the name of the third artery?
Common hepatic artery.
Yeah. So the third one, I will not draw it right now, in the sense I won't show what it does to the stomach, but I'll come to that. Okay, common hepatic. Just to complete this diagram, I want you guys to draw these 2 arteries. We'll come to these when we discuss the common hepatic. Look at how I'm joining them with each other. I'm drawing these arteries on top of the left gastric artery branches. This is the right gastric artery. Okay. I didn't talk about where it comes from. I just want you to know this. This is the, can someone label this one?
Right.
Yeah, you're correct. It's the right gastroepiploic arteries. Okay. Remember this, because we are going to need this for the cases. This is going to be clearly asked in these cases. Okay. Now, why am I highlighting these? Okay, what do you call this region of the stomach? This side of the stomach?
Inner curvature.
Lesser curvature. Okay, lesser curvature. And this is the greater curvature. Okay, it literally means the curvature here is less and the curvature on the outside is more. What are the arteries that supply the lesser curvature?
Left and right gastric artery.
Okay, you guys understand this? It's not hard. The greater curvature?
Left gastroepiploid, right gastroepiploid, and short gastro.
Perfect. Now, listen carefully and try to understand this. Can you guys see that I drift these together? In the sense, I drift them in the same region. Can you give me a name when there's two blood supplies to the same location?
Ministry.
Huh?
They are
It's a-
anastomosis.
It means, yeah, it's anastomosis, but then you can call it dual supply. You can see that there's a dual supply by the left and the right gastric arteries. Okay. And again, on this side, you can see there's a dual supply between the two gastroepiploic arteries. Okay. However, look at this thing. Look at the short gastric artery. See how far the blood has to travel? It has to come from here. All the oxygenated blood has to come from here, from here all the way here. Okay. By the time it comes halfway, the oxygen is very less. Okay. So this region is prone to ischemic damage. And when there's no oxygen, cells die. Okay. Prone to ischemia. You guys understand this? If you don't, please ask. Okay. Because in the case studies, it's all about these. Remember that the esophageal artery comes from the left gastric. Comes from the left gastric. Okay. That's it for the blood supply to the stomach and the celiac trunk. Let's take a look at the common hepatic artery. I'm gonna teach you guys why you are fat, the reason why you are fat today. Okay, we'll come to that. Now, let's draw this. This is the common, draw it big. Just draw a big vessel so that you guys won't mistake it for the smaller vessels. Common hepatic artery. Okay. Then it forms the proper hepatic artery. It forms the proper hepatic artery. And the proper hepatic artery is going to give rise to the right gastric artery. Okay. I hope it's not hard. It's simple stuff. And this will give rise to the cystic artery, left, and the right hepatic arteries. Cystic, left hepatic artery, sorry, right hepatic artery, and the left hepatic artery. Hepatic means liver, so it supplies the liver. Okay, cystic artery, it supplies the gallbladder. Okay. Now you guys can see where the right gastric artery comes from. Let's take a look at the next branch. This is called the gastroduodenal artery. I told you guys the celiac trunk supplies part of the duodenum. Here it is. Okay. I told you it supplies part of the duodenum. Now you can see the word gastro here. Can you tell me what artery of the stomach it supplies?
Right gastroepiploid.
Yes, perfect. Right gastroepitheli. Okay, this supplies the duodenum. Okay, I don't write that. It supplies the right gastroepithelial artery and part of the duodenum. Okay, this is the common hepatic artery. If you guys want, just so you won't get confused later on, you can draw arrows like these so that you know where it starts. You guys can draw arrows like this so that you won't be confused from where the arteries start. Is this okay? So there's a question, is the cystic artery a branch of the right hepatic artery? Yes, but it is also an anatomical variant where it can originate from directly from the proper hepatic. Okay, it's fine either way, you can remember it as either. Next, let's take a look at ulcers. Let's take a look at ulcers. Okay. First thing, I want you guys to know the word erosion. Ulcers for the first years, second years, these are common in conditions of gastritis. You guys, it's simply, it is common in gastritis. Just know that for now. Prashant and them, they will go into deep detail on these. These are big topics. You need to know a lot about these. They will go from the basics all the way to the treatment, management, everything. And erosion involves the mucosal layer only. So it only involves the mucosa layer. If this is the wall, an erosion, it will only hit the mucosa. Okay. However, an erosion can progress to an ulcer. Okay. An ulcer will involve deeper layers of the GI system, most notably the stomach and the duodenum. Okay. Can someone tell me why it's the stomach and the duodenum which is affected? One word.
Acid.
Yeah, what's acid?
See,
Okay. So the stomach produces the acid and it gives the acid to the duodenum. So both those regions are affected by ulcers. Okay. And that is going to cause a lot of pain. People know it as gastritis. They drink medicine for that. But then as medical students, you need to know a lot more than that. Okay. But I will just give an introduction. Next, let's take a look at the next stage of ulcers. It's called perforated ulcers. Okay. It's called perforated ulcers. Can someone tell me what perforated ulcers mean? Can someone tell me what perforated ulcer means?
It goes more deeper, right?
It basically destroys the wall. So guys, I'm not drawing a lumen here. It's the wall. Okay. This is the wall, not the lumen. Okay. I'm not drawing a wall. Here's the lumen. Okay. Don't get confused. It goes and the ulcer will basically destroy the entire wall. Oh, sorry, let me erase the top part here. The ulcer will basically destroy the entire wall. And then where does the acid fall into?
Blood vessel.
Blood vessels. Okay. The acids will come and it will destroy the blood vessels. and this can lead into bleed. This can cause bleeding. Or so for seniors, into the peritoneal space. For juniors, you can call it internal bleeding. Okay, it's going to cause bleeding. Let's understand the location of these ulcers. So let's try to understand the location of these ulcers. The first thing is gastric ulcers. Do they occur in the lesser curvature or the greater curvature? I give this line on purpose to try to trick you guys. Lesser or the greater curvature?
It's in the middle, like not on the edges.
Wait, I'm gonna, is it here, here, or here? 1, 2, 3.
3.
2.
It's actually on 1. It occurs in the lesser curvature. Okay, it occurs in the lesser curvature. So which artery is most likely to be damaged?
Left gastric.
Left gastric. Okay. Can someone tell me why it's not the right gastric? Just think. This needs some background knowledge. Okay, you guys need to know about this. But then, can someone tell me why it's the left gastric? Where do you think the parietal cells are found? The parietal cells are found in this region. Okay, we'll come to each region. So it is the left gastric artery which is most likely going to be damaged because of an ulcer. Okay, parietal region is in this region. Okay, it's the parietal cells. You find the acid producing cells, they are here. They will produce the acid which can damage the lesser curvature. And the blood vessels that is going to be supplied by this is the left gastric. Okay, the second thing, we have the, wait, don't draw that yet. Just draw it like this. When it comes to the duodenum, which artery do you think is going to be affected? Okay, we just discussed one. It's the gastroduodenal. So duodenal ulcers, obviously because it occurs next to the stomach, will affect the gastroduodenal artery. Okay. And these ulcers are found, just remember this, on the posterior surface. And it affects the gastroduodenal. Okay, it affects the gastroduodenal arteries. We did not talk about the superior mesenteric arteries yet. We didn't talk about these arteries, and they're far away from the stomach, so they are not affected. Okay. Now, let's take a few minutes and try these cases. This is for the people in my university, the first years. Our university will give you cases like this. Okay. For anatomy, it's a highly standardized paper, and they will give you cases like this. But the important thing is, the question is just going to be this. The one thing you need to find in the question is going to be this. Okay, they will give you a case like this, but then the one thing that you need to find is the anatomy question. Okay, now just try the second question first. Try the second question.
Left gastric.
Yeah. Any other answers? Okay, let me discuss this case. We have a 55-year-old man who comes to the ER with profuse vomiting over the last hour. He has vomited large amounts of bright red blood. Okay, we'll discuss this thing under esophageal varices. This is actually not related to esophageal varices. This is related to ulcers, but I'll discuss about that in that topic. Okay. His past medical history is significant for long-term use of antacids. Okay. The patient's blood pressure is low. You can see this low blood pressure means that the blood is not in the circulatory system. It's bleeding somewhere. Okay. And what our heart does is it tries to contract harder because it needs to maintain a proper pressure. So you have a high pulse. Normal pulse should be less than 100. Normal blood pressure, 120/80. Okay. And he dies. On autopsy, you see a deep peptic ulcer on the lesser curvature of the stomach. It perforated which of the following arteries? Common hepatic, no. Right gastroepiploic, no. Left gastric, yes. Gastroduodenal, this is going to be from a duodenal ulcer. And this is about a gastric ulcer. Okay. Try question number 3. Okay, this question you might need.
Gastroduodenal.
This question you might need a bit of prior knowledge. So juniors, don't worry about this. You won't get a question like this. But for the others, we have a 52-year-old man who comes due to a gnawing epigastric pain of 6 months that occurs at night or with hunger and is relieved by eating food. What type of
Duodenal.
it's a
Duodenal.
okay, it's a duodenal ulcer. Okay, Prashant is going to teach this in depth. Go for his class. He will explain all of these in his class. Now, what is important here is, what is the cause? Can someone tell me the cause?
H. pylori.
Yes. H. pylori. Juniors, don't worry. This question is not for you. So the answer here is, it's about a duodenal ulcer. Okay. And the answer here is
Gastroduodenal.
okay. It shouldn't be hard. This is how they correlate. This is clinical anatomy, basically. Wait, let me check this. Okay. Check this question and try to answer this. Send the answer in the chat, okay? Don't tell it loud. Just send the answer in the chat. So for the juniors, this patient has a tumor, cancer in the esophagus. Okay, and then they remove the tumor by surgery. So during surgery, which of the following artery is most likely at risk? Which of the following arteries is most likely to be damaged? Okay, I got some answers. It's left gastric artery. Okay. It gives a branch to the esophagus. Okay. Left gastric artery, it gives a branch to the esophagus. Now, wait, let me check if we can do this. Oh yeah. Okay, I will explain this diagram so that you guys will learn a bit about reading CT scans. The first thing is, CT scans are always read on the right side. In the sense, they always put a label that says R. Okay. And this is the right side of a CT scan of X-rays of any scan. It will be this side. Okay. So what are the organs on your right side? What is the organ which is the largest organ here?
Liver.
Liver. Is this the liver or is this the liver? One or two?
One.
One. Okay. This is the liver. Can someone tell me what this is?
Right kidney.
Yeah, perfect. I was actually hoping the person would say right kidney. And what do you think this organ is? Think carefully. Sorry?
Spleen.
Spleen.
Yes. Why is it not the stomach?
Not black. Then you should.
It should be.
Purple.
Okay. Those who are in the first year, at the end of this class, I will do a 10-minute lecture on the chest X-ray. Where I'll explain how to read. That's like the most basic thing you need to know. I'll explain that. So wait for that. This is the spleen. The reason it is not the stomach is because there is no air bubble. Okay. And also in my last class, the one I did most recently, I talked about how when there's blood flowing, it is more brighter. Okay. When there's blood flowing, it is a bit more brighter. When it becomes dull, it means there's no blood flow. Consider this organ here, the spleen. Tell me, is it region 1 or 2 which is affected by the ischemia, by the blood vessel being damaged?
2.
It's region 2. Okay, there's no blood flow there. Okay, it should be simple. Now, what is the artery which is affected? It shouldn't be hard. It should not be hard at all. This is a radiology question in the sense anatomy related to radiology. Which artery? Don't read the case. Don't read the case. Come on. It shouldn't be hard.
Splenic artery.
Yeah, it's a splenic artery. Okay. Let me check this one. I didn't come to that yet. Okay. Now I hope you guys understood this. I didn't talk about the regions of the stomach. It's fine. Let's come to that in a while. Let's go into something called the omentum. Something that most students do not understand. Okay. Okay, let's take a look at the structure. This thing called the omentum. If you know Latin, it means apron. Okay. In Latin, it means apron. Now, this is the liver. This is the stomach. Okay. Over here, we have the first apron. Don't completely draw it. You need to draw a connection here. With the duodenum, over here, you need to draw a connection here. It's a ligament. Okay. Give me a second, guys. So this is, can someone label this the first apron?
Lesser omentum.
Yes, it's the lesser omentum. The greater omentum is going to come out from the greater curvature of the stomach. Now do you see where the name comes from? The greater omentum is going to come from the greater curvature of the stomach. Okay, this is the greater curvature, and from there you get the greater omentum. It's literally a hanging apron full of fat, full of lymph nodes, different structures. Okay. Now, what did I label here? This is a ligament. Can someone tell me the name of this ligament?
Hepatoduodenal.
Hepatoduodenal. Who, the person who said that? Hepatoduodenal ligament. Okay. Let's talk about, okay, simply the name hepato means liver. Duodenal means duodenum. Most of the ligaments are named like that. From what to what, you just label it, and we'll discuss the other ligaments, the falciform ligament, all those ligaments tomorrow. Okay. Now, let's take a look at this ligament, what it contains.
Hepatic portal vein, hepatic vein, and hepatic artery.
Nice. Okay, hepatic portal vein, proper hepatic artery, and there's a cystic duct.
Cystic
Let me-
duct.
So let's draw it, but first write it down, proper hepatic artery. Okay. The portal vein and the cystic duct. Let's draw it now. So the gallbladder is found on this side. We have the gallbladder here, but its duct opens up here. Okay, it opens up to the duct from the pancreas, the pancreatic duct. It goes through the hepatoduodenal ligament. Okay. Cystic duct. Next, we have the proper hepatic artery. Proper hepatic artery, and finally the portal vein. Okay, let me use a different color. Okay, these three structures. Now, this has blood vessels. Okay, this has blood vessels, and during surgeries, this is very easily damaged. During a surgery, this is very easily damaged. This is pure anatomy. Okay, high yield anatomy. Surgery. Okay, let's take it like this. During surgery, if there is bleeding into the peritoneum, that is the space into these regions. Okay, into these regions, if there's bleeding, you do a maneuver where you clasp it with a you clasp this region. In the sense you, what do you call this maneuver?
Pringles.
Yeah, the Pringles maneuver. Okay, and this, when you do that, if the bleeding stops, that means the artery that was bleeding is due to the proper hepatic artery, one of the arteries there, the artery there. Okay. Could be the portal vein also, but then we are talking about a lot of blood loss. Let me just write it. Okay. If the bleeding doesn't stop, Keep searching. This is very high yield anatomy. Okay, you will hear this word a lot. You need to show how to do it. I don't know, in my university, we had to show how to do the Pringles maneuver for anatomy. So very high yield anatomy. And do you guys see that the lesser omentum is not continuous there? It's not continuous in that region because of the presence of the hepatorenal ligament. Okay. Now, so this part I need to explain it later. Later in the sense when we do the organ-based anatomy. But for now, this region is called the cardia. Okay, this region is called the cardia. Let's go and take a look at this case. This is the question. This is the question. People from my university, this is a typical way they will ask a question for anatomy. They will give you a case about a person and then put the anatomy part. It's not hard, but it scares the hell out of you if you're not used to these. What's the answer? Guys, send it in the chat. Send it in the chat. Yeah, it's answer D, the lesser omentum. Okay. Do you understand how they can ask these kinds of questions? For university, for licensing exams, this is from USMLE actually. But then, do you see how they ask the questions? They will put some clinical vignette and then ask you the question. That's it for the common hepatic artery and the celiac trunk. Guys, remember this statement. I need to highlight this. Just don't forget this, okay? They can ask a lot of cases from this. Now, let's take a look at the superior mesenteric artery. Superior mesenteric artery. Everything I highlighted, those are the questions that they can ask for in a clinical setting. In ERPM, whatever it is, they can ask those kind of questions because they are related to a clinical setting. It could be surgery, it could be internal medicine, whatever it is. Okay. Now, just write this. I'll give you guys a break in 10 minutes. Yeah, I'll give you guys a break in 10 minutes. Wait. Draw the opening here. Draw it the same way that I'm drawing. So this is the structures that up to 2/3 of the duodenum of the large intestine, the transverse curve. Okay. Now let's draw the artery. Guys, wait, just wait. If you drift up to here, just stay from here. Okay, now draw. Draw these loops. Draw the loops like this, okay? It looks like those things you put in your fingers to punch people. So from these loops which I drew, draw smaller loops like this. These large loops, then draw smaller loops. Okay, and from them just draw these. Okay. Highlight this region. Highlight this region. We'll come to this. There's a very high yield topic. In the sense, it tells you why people grow fat, how people grow fat. These are called arcades. These multiple, okay. These are called arcades. These are called vasa recta. Okay. Arcades and vasa recta. Do you guys see over here that this region, in this region, the blood vessel is going to pass across the duodenum? Let me draw it in another way. This is the blood vessel. The duodenum will be going like this. And the one thing that separates these two is a fat layer. Between the duodenum and the SMA, there's a fat layer. Okay. Let's talk about this fat layer for a second. People grow fat. People say, my stomach is large. Okay, my stomach is large. That's what people say. However, the stomach is here. It's not here. Okay, the stomach is here. And yet people say it's the stomach that's large. But the truth here is, there is a lot of fat. This image. Can you see these arcades? Can you see these arcades? Do you see this fat layer? So the fat that you eat, the fat that you become, it is because there's a lot of fat accumulation here. This is one location. It also accumulates in the subcutaneous region. That's true. But then the reason why the belly grows this big, here it is. There's a lot of fat here. Okay, you can see it clearly in this image. It's called the mesentery. We'll discuss those. So there's a lot of fat here, everywhere. Okay, there's a condition which is called the superior mesenteric artery syndrome, SMA syndrome. Let's just write it, SMA syndrome. Okay, in this condition, what happens is there's a sudden weight loss. Okay, there's going to be a sudden weight loss, and that is going to cause a decrease in the fat here. There's going to be a decrease in the fat between the duodenum and the SMA. Okay, so what happens is the SMA will go backwards and it will constrict, it will go and tighten the blood vessel. So let's draw it. Wait, let me see how I can draw it. Okay, it will constrict the blood vessel, the duodenum, like this. So there was a fat layer before. There was a fat layer here before, but it has reduced and shrunk. And now let's draw a fat layer. The SMA will come here. It will come here, causing an obstruction. Okay, this will lead to bowel obstruction. So okay, I have a very important question. When there is bowel obstruction, does the patient present with constipation or diarrhea? Constipation or diarrhea?
Constipation.
Yeah, yeah. It sounds like a pretty obvious question, but then some people have made a mistake in that in one of our clinical competitions. Okay. Is this okay? Let me show you. Leave this for a second. Oh, sorry. We have one more artery. Okay. Guys, take a 5-minute break. We'll do the inferior mesenteric artery and then go into the hard topic of today, the portosystemic anastomosis. The hard topics. So take a 5-minute break. We'll start at 9:35 Sri Lankan time. Guys, let's begin. Please turn on your cameras again so that I can see your faces. Okay. I actually forgot to do this question. Can someone tell me the answer? Okay. Wait. Wait. Leave this question. We'll come to that. Did you guys understand this? If you didn't, please ask. Okay. And let me just, we'll wait a minute till the others come back. So till then, let me tell you guys about the program. So today's class, it's anatomy. Okay. That's the most basic class. And we will go into all of the topics we put in the timetable, and we will start from the basics all the way to the management and treatment. So if you take cirrhosis, in that lecture, we'll start with the causes of cirrhosis, how it happens, everything, and go all the way to the end of treatment. Okay. So today's class, it's an open session for everyone. I hope you guys will get the best of this. So let's go back into this and do the inferior mesenteric artery. Okay. The inferior mesenteric artery. Our program is actually the best for students who are in the second, third, fourth, fifth years who are not going to sit for the clinical, for the exams, because we go all the way from basics, and it'll actually give you a competitive edge with others. Because if you finish these lectures, you guys are golden for anything that will come about the GI tract. Okay, that's our goal actually. There's nothing much here. It supplies the hindgut structures. So I will do the class for 1 more hour and I will stop at 10:30. Here are the hindgut structures. Okay. Here are the hindgut structures. There's 2 branches you need to know. Sorry. Yeah, it is going to supply these regions. I will talk about the internal iliac arteries and their innervations later. Okay. Supplies the 1/3 of the transverse colon, then the descending colon, the rectum, and the anus. Okay, sigmoid colon, rectum, and the anus. So these are the structures which are supplied by the inferior mesenteric artery. Basically, from the 1/3 end of the transverse colon all the way to the anus. Okay. Now let's go into the one of the hardest topics. So okay, I hope you're done. Let's go to the topic, portosystemic anastomosis. Now, as a medical student, I'm proud of Three things. One of them is I understand portosystemic anastomosis. This was one of the most confusing things for me, but then I figured it out, and now I'm really proud of that fact. Let's take a look at this. Okay. We talked about the arterial system. We talked about the arterial system to the GI tract, but we didn't talk about the venous system. Okay. Let's go into that. Okay. Just write this. Now, the venous blood returns to heart by which vessel? By which blood vessel? From the GI tract. From GI tract.
IVC.
Huh?
IVC.
IVC, true. Yeah. But then related to the GI tract, what is the vessel?
Hepatic.
Does the portal vein return directly to the heart? Or does it go to the liver?
Liver.
It goes to the liver. So how does the blood that contains all the food come to the heart? It goes to the liver. Then from there, how does it go? What's the
Hepatic
vein?
vein.
Hepatic vein. Okay. Anything that is produced by the liver goes into the systemic circulation. It goes back to the heart by the hepatic vein. Okay. That's the first thing you need to know. The next thing you need to know is all GI organs plus the spleen, they do not directly go back to the heart. Okay, they go to the liver. So I'm talking about this again. From the liver to the hepatic vein to the IVC. Okay, this is the pathway of venous return. This is the pathway of venous return. But there are areas where systemic and portal blood, portal vessels are connected. Let me explain this. There are areas where the systemic and the portal blood, portal blood vessels are connected. Now, let me draw a diagram. I'll explain this from the beginning. Don't worry. Okay, just draw this. I will explain from the beginning. If you didn't understand this, just don't worry. Don't draw what I'm going to draw now. Okay. Now, what is this portal system? Let's take a look at what this portal system is. The portal system is the blood vessels that come from the veins that come from all those arteries we talked about. We talked about three major arteries, and the veins that come from these, they form the portal system. So there will be the esophageal veins, then the gastric veins, splenic veins, all of these duodenal veins, all of these veins, they will all come back into the liver. Okay, it will all come back into the liver, and from the liver it will go back to the heart, to the normal systemic circulation through the hepatic vein. Okay, this is the normal system. However, you need to understand this thing. There are places, let's take the esophagus for example. This is the esophagus. There are places in which the systemic circulation and the portal circulation join like this. There are places like this, okay? But the blood never mixes. The blood never mixes. If this is the portal system, if this is the portal system, the blood in this will never mix with the systemic blood. Okay? Can someone try to guess why?
Pressure differences.
Yes. What about the pressure difference? Is there a pressure difference or is there no pressure difference? Think and answer.
No.
No, there's no pressure difference. The pressure in these vessels, P here, let's take it as a value, let's take it as X. It will be the same pressure in the portal system. Okay? In normal patients, the pressure in the systemic circulation is going to be equal to the portal circulation, so the blood does not mix. Do you understand that? That's the, if you don't understand this, the rest will be confusing. Okay, you guys are free to ask me if you don't understand. Next, let's take a look at the locations where these connections are. So there's this diagram. It took me a long time to draw this. Okay, let's draw it again. I'll just draw it again. But then when it comes to labeling, I will use this diagram. Okay, so let's draw it again. We have the liver, and it gives rise to 3 blood vessels that we need. The left gastric vein, and one which is a remnant, in the sense it was there when we were a baby, when we were a fetus, sorry, not a baby. And the other one all the way to the rectum and the anus, to the rectum. Okay, so let's label these. This is the left gastric vein, and this is the round ligament. Okay, now what is important here is this was where the umbilical vein used to be. This was where the umbilical vein used to be. Okay, and where is the umbilical vein connected to our body? You have something called the umbilicus. Okay, you have something called the umbilicus over here. That's where the placenta connects through the umbilical cord to the baby, to the fetus. Okay, so I'm going to draw the umbilicus here. Okay, and over here I will just draw the stomach and the esophagus. Now, these are the most important portal vessels. Let's draw the systemic vessels. Guys, draw a branch like this. Just draw a branch like this, okay? Just draw a branch like this, adjacent to each other, but not touching. This is the superior rectal vein. Superior rectal vein. Just draw this. This is called the epigastric vein. Okay. Okay, let's label these vessels. Oh, one more. This is the azygous vein. So when it comes to the esophagus, we have the azygous vein, which is from this systemic circulation, and the left gastric vein from the portal system. Then we have this round ligament that used to be the umbilical vein. What you need to know is it has the remnant of a lumen. It has the remnant of a lumen. What does this mean? It is patent that it can open up. Okay, what I'm trying to say is it can open up and blood can flow again. Okay, I hope you guys know and understand that after you are born, this becomes a ligament and it becomes non-functional. There's no blood going through this. Okay, however, it keeps that lumen. Okay, the next thing is the superior rectal vein. And there's two more branches from the systemic circulation called middle rectal vein and the inferior rectal vein. Okay. Now, let's take a look at what happens here. So I'm going back to this image, okay? This is the image I did previously. Can someone tell me, now that you understood, there's going to be equal pressures here. What happens in portal hypertension? What happens in portal hypertension?
Pressure in the portal vein
Pressure
increases.
in the portal circulation is higher
Yes.
than the
And then what happens? What will happen to the blood? Can you guys understand this? Now the pressure in the portal vein is greater than that of the systemic circulation. Okay? Pressure in the portal vein, portal hypertension, high blood pressure in the portal vein. Portal vein pressure will be greater than the systemic pressure. Okay? Portal vein pressure will be greater than the systemic pressure. And that will cause something like varicose veins. Look at this here. This is due to portal hypertension affecting the esophagus, the regions of the esophagus. It will cause damage because these vessels will start to enlarge. All these vessels will start to enlarge. Okay? And when they enlarge, can someone tell me the name of this? When these vessels over here they will enlarge like this. What do you call this condition? When it's in the yes, it's called esophageal varices. And these vessels, they can enlarge and obstruct the lumen. It can obstruct the wall. Okay, look at how I drew a small hole here. So it can come and obstruct the wall like this, and sometimes due to the high pressure can bleed. Okay, these esophageal varices, they can bleed, and this is most of the time silent bleeding. When I say silent bleeding, the patient won't know it is bleeding. Okay, so, and this is life threatening. Okay, this is a life threatening condition in which the patient can bleed silently. However, sometimes there can be a vomiting of blood. Bright red blood can come out sometimes, but most often it is silent bleeding because there's gravity. It goes downwards. Okay, it goes to the stomach. Then there's peristalsis. It will move the blood downwards. How do these patients present if there is severe bleeding? What's the sign? Have you heard of something like this? Basically, black tarry stools. Because there's blood, it can cause black tarry stool. Okay, the blood is going to be processed. It is not going to be bright red blood. Okay, this is processed blood. The blood will be broken down. I need to highlight the importance of this because we are going to come to something over here. Okay, when there's bleeding somewhere here, it is not going to be processed by the enzymes. It's just going to come out. Okay, black tarry stools.
So hematemesis is not common, is it?
Hematemesis can also occur. That is throwing up blood. Okay, it can occur. There are patients who present with that. It's not uncommon, but the problem is the life-threatening problem here is the silent bleeding or the severe bleeding which presents with black tarry stools. Okay, let's just write hematemesis. That is throwing up blood. Okay, that's the first part. The second part is, now that the portal pressure is increased, it is also going to open up this lumen. Okay, it is going to open up this lumen, and then it is also going to cause blood to flow into this region. It will cause blood to flow into this region. Okay, and they become dilated. They become like a varicose vein. What do you call this condition? When there is
Caput medusa.
exactly. Okay, caput medusa. Now this is not my chapter. Portal hypertension is, I think it's Sasanga's. He will discuss these. He will go into more detail. Caput medusa. Reason, it looks like the head of Medusa. Okay, you know Medusa, the Greek lady, the scary lady with the hair that has snakes. Caput medusa. Okay. Do you guys understand these? It's not hard. Okay, but then it was one of the hardest for me back in the day. And finally, let's talk about a condition called hemorrhoids. Okay, hemorrhoids. Pressure increases, goes here, dilates these veins. There's going to be dilation of these. Okay, and they can bleed. So the pressure will increase, cause dilation. These can bleed. Hemorrhoids. Okay. So let me just go into a bit more detail about these varicoses. Varicosis is a condition in which the blood vessels, the veins, become tortuous. They become twisted, turned like this. It is more common in the legs, and it is more common in females. Okay. Normally, the vein is supposed to go up like this, in a smooth. Even if it turns, it has to go in a smooth turn. There are valves, but varicosities are basically tortured veins. Okay. Bleed hemorrhoids. Do you know the difference between internal hemorrhoids and external hemorrhoids? Don't write this. We'll discuss this. Internal and external.
The pectineal line.
Sorry?
If it's outside the pectineal line, it's
yes, pectinate line. Yes. It is external. Now, which one causes pain? There's two types of hemorrhoids. One is painful. The other one is painless. Which type causes pain?
internal.
Actually, it's I'll explain all of these. This causes, okay, I wrote the same thing here. This is painful. This is painless. Okay. Is that clear? This whole topic, portal hypertension, this is under liver diseases. I'll be doing part of it. Prashant and Sasang will also do part one. So, yeah, that's it for that. Let's go into, do I have a case for this? No. Let's go into the pectinate line. Another hard concept which we need to know. The pectinate line. Let's draw that. Guys, draw it with me. I have sent the diagram in the note. You guys can look at that and draw it. Because I will end up using that diagram. Just draw this for now. And draw a line here in the middle. This is called the pectinate line. Okay, this is the pectinate line. Let's go back into embryology. If you haven't learned this, don't worry too much. We have 3 germ discs. What are the 3 primary, the secondary germ discs? What are the 3 germ discs? Oh, sorry.
Ectoderm, endoderm, and mesoderm.
Yes, nice. Ectoderm. What does it give rise to? Ectoderm. Embryonic ectoderm. Embryology.
Skin.
Skin, and one very important structure.
Nervous system.
Yes, never forget that. Okay, nervous system. Then the mesoderm is inner to that. What does the mesoderm give rise to? muscles, connective tissues, and so on. Okay, and also this is important, especially if you plan to do USMLE, the spleen. Okay, the spleen is a derivative of the mesoderm. The reason I said spleen here is because the endoderm gives rise to the GI tract. There's three discs. There's three discs that you will learn in embryology for my university, I think second semester. Ectoderm, mesoderm, and the endoderm. Okay. The endoderm gives rise to the GI tract. But look at this end here. I did not complete it. Okay. Because this section below is going to be from the ectoderm. And the section above is from the endoderm. Okay. You guys understand this? I had to go all the way to this to explain that tiny concept. But it's fine. Endoderm and the ectoderm. Okay. Now, let's take a look at the nerve innervations, the blood vessels, and the lymph nodes. And just remember this, in the middle, keep a bit of space when it comes to the blood vessels. Okay, keep a bit of space because I'll be drawing the hemorrhoids there. First, the endoderm. This is going to be the visceral innervation. Visceral innervation. And the region below the pectinate line, it will be somatic innervation. Can someone tell me the meaning of somatic? Nervous system. Does anyone know the meaning of somatic innervation?
That controls the voluntary movements.
Oh, sorry?
That controls the voluntary movements.
Okay, it is related, but not really. Somatic means body wall. What you said is correct. That is because it innervates the muscles, the skeletal muscles. This is a somatic innervation is the body wall. Somatic means body wall. Okay, the wall of the body. This is visceral innervation, or you can just remember it as inside. Okay, these are big words with a very simple meaning. Okay, you can Google it, you will get a big definition. That's not necessary. Just remember, visceral means inside, somatic means outside the body wall. Okay, now let me ask a question. In appendicitis, you guys have heard of something called the McBurney point. Okay, if you haven't learned it yet, you'll learn it. You have heard of something called the McBurney point. Okay, is it because of innervation from the visceral or from the somatic wall? Okay, let me ask it in a different way. An appendicitis patient, do they first present with pain in the McBurney point, or a generalized form? How does the pain present?
Generalized form.
Why is that?
Visceral.
Yes, reason is it is innervated. The appendix is going to be innervated by the visceral innervation. Okay, and when it is inflamed, one of the hallmarks is pain. So this same visceral innervations will be supplying all around in that region. Okay, the first pain will be generalized. The second type of pain, the reason it migrates to this McBurney point is when the inflammation spreads to the peritoneum. Peritoneum. Okay. Once the inflammation migrates to the peritoneum, that's when you get pain in the McBurney point. That is somatic. Okay, body wall. It is localized. Okay. We will discuss these tomorrow. I'm doing the enteric nervous system. I'll be discussing these tomorrow. Okay. Now that you guys have some idea about the somatic and the visceral innervation, let's go into the lymph nodes. Okay. These drain into inguinal, internal iliac lymph nodes. These above the pectinate line, they drain into the internal iliac lymph nodes. Okay. However, these drain here. Superficial inguinal, INGUINAL lymph nodes. Okay. Let me show you where the superficial inguinal lymph nodes are. I will have to. It is in this region. Okay. It's like it will be here. Okay. That's where the superficial inguinal lymph nodes are found. Okay. Now, let's take a look at the blood vessels. Here we have the superior rectal artery and vein. Artery and vein. Okay. Remember that from here? Remember that from here? And down here, all the way at the bottom, you have the inferior rectal artery and vein. Okay. It's not too hard. Now, if there is hemorrhoids, if there is these enlarged blood vessels which easily bleed, these can easily bleed. These can easily bleed. Okay. It could be from the top part, or it could be from the bottom part. Okay. Now think and tell me, which is painful? These are called, this will lead to internal hemorrhoids. Okay. And also the location of a type of tumor called adenocarcinoma, this region. Adeno means gland. Carcinoma is a malignant tumor, cancers. Okay. Cancers that originate from glands. Now, internal hemorrhoids, is it painful or painless?
Painless.
Painless. Okay. Painless due to visceral innervation. Okay. Due to visceral innervation, this is painful bleeding. Hemorrhoids will bleed painlessly. So a patient will present with painless bleeding. Painless. What is going to be the color of the bleeding? Is it going to be black tarry stool or red and bright red?
Right.
Bright red. Okay. Reason for this? There's no enzymes. There's no enzymes to destroy these blood. Okay. There's no enzymes which will break down the blood. Okay. Clinical. It's a clinical correlation you need to know. Next, let's talk about the external hemorrhoids. This is where, the hemorrhoids that occur from below the pectinate line. This is painful due to somatic innervation. Okay, and external hemorrhoids, also fissures, and squamous cell carcinoma. Okay, squamous cell carcinoma. Squamous cells are usually cells. Okay, squamous cells are found in our skin. It is closer to the skin. Just remember it like that. And one more important thing you need to know about these is they drain into which lymph nodes?
Superior inguinal.
Superficial
Superficial inguinal.
inguinal. Okay, so by the time the patient presents, there will be a palpable mass. There will be a palpable mass in the superficial inguinal region. Okay, did you guys understand all of these? If you did not, please ask. Fissures basically means you have seen what an earthquake looks like, right? Basically, there's going to be cracks. Okay, fissure means you know what an earthquake looks like. It's the same thing here. There will be a lot of fissures. One reason there's going to be scratching, right? One cause of this scratching, which leads to damage, because this is a painful lesion. This is just one cause, okay? The scratching. That's it. Try these two cases. Wait. Try these two cases. IVC means inferior vena cava. Send your answers in the chat. I'll give you guys 1 minute for the first question. Question number 7, actually. Send your answers in the chat. For the newcomers, here is the question. In the sense, students from the first year. She's constipated. She doesn't want to defecate. So that will lead to retention of feces, leading to constipation. Okay. Here, there's another statement which is for the same. Does the port? Okay, right. Okay, my question: does the portal vein drain through the inferior rectal vein? Check again. Okay. The inferior rectal vein is part of the systemic circulation. Drains into this. I hope you guys understood. Okay. The answer is A. Inferior vena cava via the inferior rectal vein. So what has happened here is this is the external hemorrhoid. Okay. And then this has led to pain, and they are asking, where is this external hemorrhoid coming from? It is due to inferior rectal vein, and this drains into the inferior vena cava. Remember, the superior rectal vein, it drains to the portal system. That's correct. But this is internal hemorrhoids. Okay. Now try this question. Question number 8. Try it. So yeah, the answer is A. Okay. Let me explain that. This is a malignant squamous cells. Okay. Rectal exam. Okay. Let me go all the way back. This patient's lymph nodes are palpable near the inguinal region. Okay. Near the inguinal region, these lymph nodes are palpable. And they check to see if it is a prostate tumor or if there's an enlarged prostate. No. They do a biopsy of a rectal mass and it shows squamous cells. And we discussed here, squamous cell carcinoma drains into superficial inguinal lymph nodes, and it's a tumor which originates below the pectinate line. Okay. Yeah. Hope you guys understood this. Let's go into esophagus. We'll end the class from there.
So,
Yeah.
does portal hypertension only cause internal hemorrhoids?
No, it can cause external hemorrhoids also. It's just this case is about they are asking about an external hemorrhoid. Okay, it's asking about severe pain. There's pain here. If they don't talk about pain, but they talk about bleeding, if they tell about symptoms of internal hemorrhoids, then you can go with this answer. Sorry. Okay. Did you get the answer? If not, please ask or send me a message after. This case is about severe pain with defecation. And actually, this is not just because of portal hypertension. Okay. There are other causes. Now, let's go into the esophagus and we'll end the class for today. Before that, the anatomical thing that most people forget, most people don't really focus on. I hope you guys know what this checkers board is, this tic-tac-toe board is. Where is the epigastric region? Let's label some regions. Where is the epigastric region?
Two.
This is the epigastric region. This is literally the first lesson of any anatomical chapter. Where is the hypochondriacal region? Hypochondriac region.
1 and 3.
Yeah. Is this the left or the right anatomical?
Right.
Right. For the newcomers, remember, you always look at a patient as if they're standing in front of you. Okay. So this is the patient's right side. And this is the left hypochondria. Where's the umbilical region?
5.
Yeah, this is where you get the umbilicus. Okay. And where's the lumbar region? Is it here? Tell me the number.
6.
4 and 6.
Yeah. Right lumbar, left lumbar. And the iliac region, is it here or here? Which region? Iliac.
7 and 9.
Yeah.
7.
What is the last region?
Hypogastric.
Hypogastric. Now, we have all of these. Can you tell me what is the main organ which we find in the right hypochondriac region? What are the organs? Tell me at least 2.
Liver.
Liver and gallbladder. Okay. The epigastric region, tell me 2 organs.
Pancreas.
Yes. Pancreas, yes. What else?
Stomach.
Yes. What else?
And a little part of the corner of the liver.
Yeah. So we have the liver, stomach, pancreas, part of the spleen. I'm just going to highlight some of the main organs. Okay. Reason, we are going to learn about pain presentation, a bit about pain presentation, how pain in these regions present. Left hypochondriac region, what do you think is there?
Spleen.
Spleen. Okay. And bit of the pancreas. Then right lumbar.
Liver, okay.
Yeah.
Kidney.
Yeah. Knees. Yes. That is correct.
Ascending colon.
Yes. Ascending colon, the colon that goes up. And also you can consider the gallbladder. What about the umbilical region?
That's fine.
The duodenum, small intestine, those stuff, okay? And also the transverse colon. What about the left lumbar? Just think of yourself. There's nothing to memorize here. Literally nothing to memorize. Just think of your body. Think of where these organs are, okay? If you know where they generally are, that's good enough. Left lumbar.
Sigmoid colon.
Descending colon.
Oh,
Or descent.
descending colon, yes.
Descending colon.
And also the left kidney, okay? What about the right iliac? Two organs, two structures?
Appendix.
Yeah.
And cecum.
Yes. And the cecum. And now tell me here, the hypogastric region?
Bladder.
Bladder.
Bladder, yes. Remember this, the bladder is here, okay? What is behind the bladder? In a female.
Uterus.
Yes.
Uterus.
Yes. And what is behind the uterus?
Rectum.
Rectum.
Tongue.
Okay. In this, it's the sigmoid colon, the rectum, those regions. Okay. Bladder. So if you are to send a needle through this region, it will hit the bladder first, then the uterus, and if you go all the way through, it will hit the rectum. Okay. So bladder, reproductive organs, and the sigmoid colon. Rectum. And this will have the descending colon, part of the descending colon, and the sigmoid colon. Okay. Now, this is something I can give you as a guideline when it comes to pain in the GI tract. If they say epigastric pain, the patient presents with epigastric pain, where do you think what should you think about? Yeah, it could be pancreatitis. What else? Ulcers, or it could be gastritis. Okay, epigastric pain. Okay, and if they say left lumbar region pain, and it seems like a situation with the GI tract, if the case is about a GI tract and there's pain here, what do you think is most likely the case?
Obstruction.
In the sense it's going to affect the descending colon. Do you understand that?
Horse.
Huh?
Constipation or horse?
No, yeah. No, I'm not asking the symptoms. I want you guys to understand when they're talking about cases. This is clinical anatomy. When they talk about pain and they talk about different regions, if they say epigastric region, think of pancreatitis, gastritis. Just look at the glands or the organs there and think of a disease of that. Okay. Now the descending colon, let's say there's ischemia. Here's the colon. And there's ischemia of this region. What do you call this region? What is this region called? There's a special name for this.
Splenic.
On this, yes. What's the name?
Splenic flexure.
Yes, splenic flexion. in cases they will commonly say left lumbar pain, think the descending colon and the splenic flexure. Then it's very easy. The reason they call it splenic flexure is because the spleen is here. And over here we have the liver. So what do you call this flexure?
Hepatic flexure.
Hepatic flexure. Okay. I know it's a long class. And do you guys understand this concept about pain? Do not memorize this. Never memorize this. The only things you need to memorize would be these names: hypochondriac, lumbar, umbilical. Everything else, just think of your own body, okay? And just relate it to that. If there's right hypochondriac pain, if there's pain on this side, it could be due to gallbladder, inflammation of the gallbladder. If there's pain in this region, it could be due to appendicitis. Okay, just think of these kinds of stuff when it comes to cases. Let's see if, okay, try this question. Just try this question. You can send the answer to the group. Okay, we are done for today. What do you think is the answer?
Hepatic vein.
Yeah, it's not hard, right? The answer is hepatic vein. Oh yeah, it's hepatic vein. It's not. So the labeling is weird, but the answer is hepatic vein. This is a tumor. Tumor means an abnormal mass. Okay, a cancer for the newcomers, but then that's a very wrong concept. This tumor is producing IGF-1. Another name for this is somatomedin. It's under endocrinology. So this will be released. How can it enter into systemic circulation? We discussed this. It has to go through the hepatic vein into the IVC back to the heart. We discussed this, okay? We are going to learn more about a tumor that produces serotonin. We will be learning about this. Actually, that's under endocrinology, but I'll be doing this chapter on the 19th. I'll see if I can include that. Yeah, that's it for today. The juniors or anyone else who hasn't learned how to read an X-ray, you guys can stay. The others, we are done for today. Tomorrow, so tomorrow is not a free class, okay? If you guys, if you want to join the program, just I will send the registration notice. You guys can check and join. Yeah, tomorrow is not a free class, so tomorrow I will be discussing these topics, the organs of the GI tract. Okay, we are done for today. Those who want to learn about X-rays, you guys can stay. Others, see you guys. Good night.